All right, next up, we have Limbani Makawa. Limbani is the Integrated Disease Surveillance and Response Coordinator at the Ministry of Health Malawi. She will be discussing a cholera outbreak in Mchinji District, Malawi, epidemiological trends, public health response, and lessons learned.
Thank you, John. Thank you for having me. We've had a lot of great talks today, and I've enjoyed each and every one of them. But I want us to just take a break from the data analytics and just listen to a story. So I'm going to tell you a story about an outbreak in Mchinji District, that is in Malawi. So for us that for us that don't know where Mchinji District is a border district in Malawi, a small country in the southeastern Africa that borders Mozambique and Zambia. It has a population of just over 700,000 and has 19 health facilities. WASH indicators is very poor in the district, and WASH indicators is very poor in the district, and the previous outbreak that we had was in 2008 with a case fatality of just under 1%. But in 2022, we registered one of our worst outbreaks with a case fatality of just over 3.9%. So I set out to just describe the outbreak using data from treatment centers that we had in the district. The outbreak started in November of 2022 with an index case that was registered on 12 November of 2022. This was a fisherman from another district that was 200 kilometers from the district. He came to the district specifically looking for better access to healthcare and also to be with his mother and wife who were based in the district. So we treated that case. 2 days later, we had 2 more cases that we registered. So, okay, we had 2 more cases that were registered. This turns out to be the mother and the wife of the index case. We managed those cases, and we thought that was the end of it. And then days later, we started receiving cases from the same village where the index case arrived in. We managed that initial outbreak, and we thought this was one of the localized outbreaks that we usually have in the district. But in January of 2023, we started receiving more cases from another village, and this village is along the Malawi-Mozambique border, where connectivity and interaction between populations from Malawi and Mozambique is very high. We're managing those cases, and in February, that's when we received our initial cross-border cases. And that's when we realized that we are dealing with a much larger outbreak, and that the outbreak had spread across the border. Cases kept on increasing, and we started registering a high fatality in the months of February and March. And then we realized that our capacity at district level could not manage to contain the outbreak, and we needed support. So we reached out to the national level for support, and we were assisted through the WHO in implementing an intensified cross-border WASH interventions, which saw the number of cases dropping to 0, and the outbreak ended in May. So when we started receiving our cross-border cases in February, it also drove the case fatality level very high. So in February, that's when we registered our highest case fatality rate, followed by March. And then cases dropped drastically in April following the interventions that were implemented in that particular month. And this also correlates with the rainy season. The rainy season in 2022 started in January, and this was the initial rainy season, and it peaked in March. So there was a correlation in the number of cases that we saw with the rainy season. Going to the distribution of the cases, the spatial distribution of the cases, you would appreciate that Like I said, Chinchi is on the borderline. So this is the borderline. There's Mozambique and Zambia, and most of the cases were concentrated in these two health facilities. This is Gilimi and Tembo Health Facilities. And this saw the largest number of cross-border cases that we registered in the district. So Gilimi had the highest case fatality of over 15.5%. And it registered about 51% of cross-border cases. While the other facility, this is the closest to the Mozambican border, it had over 83% of all cases that were imported, with only under 20% of local cases. But the case fatality rate in that particular facility was 0.9. We'll see how that was about. And then the general fatality was 3.9. We had 16 fatalities for the 405 cases, but 10 cases or 62.5 of those were imported, and these fatalities were due to delayed in access to healthcare. They usually arrived very late at the facility for care, so they would arrive severely dehydrated, that resuscitation was not even possible. We couldn't locate the veins to rehydrate them. So this drove the case fatality rate up to 16%. Even for the local fatalities that we had 6 of them. 4 of those were community deaths, where it was also attributed to delays in seeking access to healthcare. 2 of those died in facility where they had other complications. The distribution in terms of sex and age, there was not much significant difference in terms of males and females in terms of attack rates. But we observed that the number of cases from new infections was higher among females in the 20 to 29 age group. This was attributed mainly to the caregiving responsibilities culturally that is assigned to women that are actually married. And we for the risk factors that drove the transmission, we identify 3 major risk factors: lack of access to safe water, inadequate sanitation, and community resistance to cholera preventive measures. You'd appreciate that this latrine is the one that was used by the index case. So the index case arrived here in this particular village and was using this latrine, which is about just 14 meters closer to the shallow well. And this is a community shallow well where it's the whole community drinks water from this shallow well. It's this one here. We tested this water, and qualitatively, it was positive for fecal contamination. We didn't have the capacity to do quantitative tests where we can identify and isolate Vibrio from the water, but it was positive for fecal contamination. This is a shared water point from the second village that we had our second outbreak. That's shared between Malawian and Mozambican villages, so they drink from this water. This water was also positive for fecal contamination quantitatively. And this river is also used by populations across the border, and it was also positive for fecal contamination. But the factor that drove transmission was the community resistance to cholera preventive measures. So we implemented several water and sanitation interventions, but utilization of those interventions was very, very poor. For example, the utilization of chlorinated water, we were supplying chlorinated water to all water points, to all households that were affected in villages that that were at a higher risk. But utilization of that chlorinated water was very low. People reported that the chlorinated water do not taste good, it tastes funny, it doesn't smell really good, and they would prefer drinking the groundwater that they are used to. And also there's poor adherence to wash measures. We had an intervention where we were promoting everyone to have a latrine where they could use with a hand washing facility. But that was met with resistance in terms of people have their way of doing things, and they preferred that way, citing that they have lived that particular way for so long, so they don't see any need for having a latrine. So they would prefer to continue open defecating in nearby bushes that they are used to. So these two factors drove our transmission very, very high. So we implemented in multifaceted interventions focusing on cholera education, water and sanitation interventions, and case management. So through the support from WHO, we implemented cholera education campaigns through roadshows targeting the Malawi-Mozambican borderline, reaching to both Mozambique and Malawian villages. We also had cholera engagement meetings with local leaders from both sides, Malawi and Mozambique. And this was a very high impact intervention in a way that we had to identify drivers of transmission from this engagement meeting, which later informed targeted interventions that we implemented that saw the drop in the number of cases. So from here, that's when we plan to distribute chlorine in both Malawian villages and Mozambican villages, and use these local leaders to enforce utilization of that particular chlorinated water. In case management, we established oral rehydration points along the Malawi-Mozambican borderlines, targeting transition routes where cases from Mozambique were using to seek health care services in Malawian health facilities. So we targeted those cases that reported traveling long distance, that were getting to the facility severely dehydrated. So we thought if we could have the oral rehydration points along those transit routes, we would at least provide ORS to the cases as they go to the facility, so that they wouldn't arrive at the facility severely dehydrated. And it worked very well. It actually cut the number of fatalities from cross-border cases to 0. WHO helped us with deployment of such staff to support high burden for CTUs, which saw outcomes improving. And also, it helped us in establishing cholera camps in all high burden health facilities, especially those along the Malawi-Mozambican border. So what we learned from this outbreak? 3 major lessons. Cross-border collaboration is very essential for effective outbreak response in diseases with fate potential. We had struggles reaching out to Mozambique because of the jurisdictional challenges between countries. But we managed to have the local leaders from Mozambique, and we engaged them, and we saw a high impact from that particular engagement. If we did not do that, we couldn't manage to control the outbreak. And also, there's an urgent need to improve water and sanitation infrastructure to prevent future cholera outbreaks and similar public health emergencies. Apart from just improving the infrastructure, there's also a need for heavy investment in behavior change for the local people in the district. Also, timely and sustained public health interventions are essential in containing outbreaks and reducing spread and improving patient outcome. We delayed in responding to the initial outbreak, which we saw the outbreak spilling over to Mozambique. But if we responded on time and controlled the initial outbreak, we couldn't have this particular very, very worst outbreak that we had in the district. So moving forward, we plan to use this data and the data from the previous outbreaks that we had to model, to simulate future outbreaks that can actually help us to be prepared in terms of whenever we have another outbreak, or in the likely occurrence of another major outbreak, we will know what to do and what to expect. That's the end of my presentation. Thank you very much for listening.
Thank you, Limbani, for a great talk. Do we have any questions from the audience? Elizabeth.
Thanks for the presentation. I was wondering, on the topic of cross-border collaboration, if you could comment on your ability to share surveillance data with the other countries, and if you could talk, share the descriptive epidemiology, like some of the summary statistics and things that you were finding. Was that something that you were also able to do in addition to the control measures? Thanks.
Thank you very much. Great question. On cross-border collaboration, we have a lot of challenges in our cross-border zone. We work in zones. So our district is in a zone with Chifunde district in Mozambique and other 3 districts in Zambia. So we have a very good platform with Zambia. We have platforms where we share data. We do integrated interventions, we do joint interventions. But with Mozambique, we have challenges because in Mozambique, during the cholera outbreak in Mozambique, they did not register it as cholera. They were just saying acute water diarrhea. So for us to work together, it was a very challenge because they were not willing to say that they have cholera. And also, I would just go ahead and say it. Bureaucratic challenges that we faced in reaching out to our counterparts in Mozambique. So the only way we had an effective collaboration was through the local structures. So the local leaders and the local people, because we are one people. So we are people from Malawian villages and Mozambique, they're just separated by a road or just an imaginary boundary. But normally they are one people, they intermarriages and everything in there. So we used that opportunity to reach out to Mozambique. But officially, from the Ministry of Health in Malawi and the Ministry of Health in Mozambique, it was very difficult for us to do that. But we still had to find a way to do that. So descriptively, I wouldn't have data for Mozambique. I would only have for the villages that we reached out to and the interventions that we provided to Mozambique. But because of these challenges in collaboration, we couldn't have established the extent of the outbreak on the Mozambican side. Thank you.
Thanks very much for that presentation. Maybe just building on the question from Elizabeth, how are you confirming the cases in the 2 countries? And would the deployment of WHO-approved rapid diagnostics facilitate that communication and sharing, do you think?
Thank you for that. Diagnostically, we use culture, where all cases were tested through culture. But in the stage of the outbreak, when the cases were at its peak, we were now using just rapid diagnostic kits, where everyone that turned out positive was considered as a confirmed case. But in the initial phase of the outbreak, we were testing every case. We reached out to WHO for the collaboration, but we had one collaboration meeting that was at national level. And at national level, they had their priorities. So we couldn't really establish a forum or a forum where at district level, at subnational level, we could have an effective collaboration. But at national level, through the help of WHO, we had such collaboration initiatives with neighboring Mozambique. Thank you.
All right, why don't you join me in, do we have another, okay, yes, go for it.
Sorry. Thank you so much for your presentation. I was, really interested to hear the distance. You mentioned folks traveling quite a long distance to get care in for this most severe of cases. I was just wondering, I guess, how you think that relates to, the data you have on the outbreak. whether they're anecdotally, you think it might be the tip of the iceberg. And, from those communities that traveled quite far, were there more maybe mild cases that didn't come into the health facilities? How do you think, I guess, the surveillance data you have maybe is representative of the region, or whether it's an underestimate? Thanks.
That's a great question. I would totally agree with you. The data that we have could be a very big underestimation of the cases that we had, because we had a lot of cases that did not go to the facility. Even local cases in the district, most of them could not go to the facility, and we had challenges with our surveillance system in detecting those local cases at community level. So in Mozambique, Mozambique is vast, and their health facilities are very, very far from each other. And the nearest facility for the villages that we were receiving cases from, the nearest facility was over 20 kilometers away. So that would lead to contamination of the environment, and that would drive the transmission if somebody is walking with acute water diarrhea over 20-kilometer distance. So that would contribute a lot to transmission in the neighboring villages that we're actually using to transit to the facility. And yes, that will lead to a lot of mild cases in those particular villages that we're using to get to the facility. So yeah, the data would be, yes, an underestimation of the problem that we had. Thank you.
All right, we have time for one quick one, maybe 2 to 3 minutes.
Thank you for the presentation. My question is, looking at the epidemiological trends of the previous outbreaks, have you seen a change in the geographical hotspots, or have they been static across the country?
Thank you for that. For the country, I wouldn't be able to give you that data, but I'll give you that for the district. Yes, there's been a very big change, because in the past we usually have sporadic outbreaks that we localized in inland, not along the border, but in facilities that are inland, in places where we have rivers that people use water for irrigation. But this one totally changed that. All the cases, most of them, a large number of the cases were along the borderline. Thank you.
Very good. Thank you for the great questions and discussion. Join me in thanking Limbani.